Hi, my name is Adine Turner. I've been a physical therapist for over 25 years. On top of teaching orthopedics, I have also given many national presentations on musculoskeletal disorders. My passion is to bring awareness to the overlooked musculoskeletal epidemic. The cost and disability rates have skyrocketed. MRIs and surgeries have increased by triple digits since the 1980s. But with all our advancements, this has only led to an increase in care and poorer outcomes. In this presentation, we will outline the specific man-made causes that have led to this epidemic and the simple things we need to do to decrease chronicity and pain. An overview of the numbers show that every 1 in 2 Americans suffer from a musculoskeletal problem, costing over $796 billion a year, and they are the leading cause of disability in the world. This graph shows the self-reported rate of medical conditions in the U.S. in 2015. In the middle, you can see diabetes with a rate of 9.3%. But at the very bottom is actually musculoskeletal conditions with a 50.3%. We hear so much about the diabetic epidemic. What about the musculoskeletal? Comparing the numbers, there are 30 million Americans that suffer from diabetes, costing $327 billion a year. But there are 102 million that suffer from musculoskeletal disorders, costing more than double what we spend on diabetes. Even more staggering is the 117% increase in cost from 1996 to 2011. Reducing the cost and rate of disability is actually simple. If you know the secrets, or basically the latest research, and willing to get out of your comfort zone, because our current best practices have not advanced care. Instead, they're actually making people more disabled and at a dramatic rate of over 50% since 1996. The first of these secrets is early access to proper care. Early access, that's pretty well understood. But at the same time, we got to remember 50% of those with chronic pain have never been told to exercise. So the second part of it, proper care, is where we have to dive into. One way to quickly assess if proper care was received is to simply look at the patients that go on to become chronic. And as we can see from this graph, in 2012, the number of those suffering from chronic joint pain is staggering, even in the younger ages. The secret to understanding chronic pain is to know the cause. And although chronic pain is very complex, the cause is quite simple. Fear. For you cannot have chronic pain without fear. It's so important, I'm going to say it again. You cannot have chronic pain without fear. And we look at the high cost of musculoskeletal disorders, we need to see what's eating up most of it, and that is the chronic conditions and the surgeries. And these are the first two things that we must address. How many physicians, PTs, nurse case managers address this? Pain is complicated. Yes, the patient's background, emotional trauma, anxiety, all contribute to how their pain is felt. But what if fear is addressed on day 1 and again on day 2, 3, and 4? Addressing fear is just as important as asking where their pain is. A patient's fear is usually first centered on a misunderstanding of their diagnosis. For example, degenerative disc disease. Patients with this always come in feeling that they have a disease that is going to get worse and worse, when it's simply the natural aging process for anyone over 35. But it could also be fear of lifting, fear of returning to work, fear of doing that activity that first triggered their injury. All of this must be addressed on day 1, 2, 3. When someone receives a diagnosis, it's a negative event and must be balanced with education or instructions on how to manage it. For example, the diagnosis of a herniated disc and sciatica. Well, there's simply a cut. A cut in the disc heals exactly like a cut on your knuckle. If the pain's shooting down your leg when you're sitting, what happens if we correct your posture? Does your symptoms or sciatica centralize? This would be the same as if you bend a cut on your knuckle and then straighten and apply overpressure. The bleeding stops or centralizes. In my opinion, the MRIs had the biggest contributing factor to the musculoskeletal epidemic. MRIs were first developed in the 80s, and they absolutely revolutionized our ability to see structures. They were able to show a sensitive and accurate picture of spinal anatomy, for example. But when we do not properly educate patients, the MRI becomes contagious for spreading fear. By the time you're 40, you have a 60% chance of having an asymptomatic disc bulge. And by the time you're 50, you have an 80% chance of having a bulge and arthritis that's asymptomatic. This is the normal aging process, just like gray hair on your head. It's normal and painless. And this research was published back in 1994. When you have blood work done, you're provided with an average range for normal. But when you receive an MRI, all changes are considered abnormal. Several research articles have shown the inability to actually link spinal MRIs to patients' symptoms and function. New research published just last month actually found no correlation between lumbar MRI findings and intensity of pain, quality of life, anxiety, and depression in 200 subjects with low back pain. The only correlation was age and BMI. A picture is a picture. It does not necessarily tell us about pain and function. For example, does this computer work? We can clearly see the dent, but only by using the computer can we tell if it is actually damaged. Likewise, the MRI gives us a very clear picture of our joints and muscles, but that picture does not tell us about pain or function unless we see something catastrophic. MRIs play a vital role, but should be used sparingly and only for those with red flags. Otherwise, we are just creating a sales funnel and the most elaborate one ever known. Having an MRI increases your chance of having surgery, injections, seeing a spine surgeon, and even going to the ER. You are actually worse off. Why? You've been told something's wrong. The seed of fear has been planted, and you will do whatever you need to do to fix yourself. Physical therapy is a 7-year degree for which most of their time is spent studying musculoskeletal disorders. Early PT has been well documented to reduce not only healthcare utilization, but also opioid prescriptions, unnecessary x-rays and MRIs, and the need for surgery. The most significant finding is actually the cost savings, especially with direct access, or the ability to go directly to a physical therapist without a doctor's prescription. With the well-documented cost savings, faster recovery, and improved outcomes, I have yet to understand why insurance carriers are not actually pushing for those in pain to go directly to a rehab specialist and skip all the steps in between. Again, early access to proper care. Proper care must include keeping the patients active and at work within reason, and avoidance of passive care. Why? Because this has been shown to have the best outcomes. Bed rest slows the healing process, while the right or proper activity stimulates. Passive care includes all the treatments in which the patient does not actually direct. This is a really hot button because it includes our most common treatments that we use today, such as modalities, injections, mobilizations, manipulations, surgeries, etc. The hands-on skills and human touch have a vital role in healing, unless they keep the patient in the back seat. We have to be very careful when we promote that our special skills are required for healing, because we are actually promoting helplessness, which in turn triggers increased healthcare utilization and longer injury duration. Instead, we want to promote empowerment. Patients love to be taken care of, but for the best outcomes, passive care must be kept to a minimum. Studies do show the effectiveness of passive care by themselves. The problem arises when we compare their effectiveness to just exercising alone. Passive care can be very beneficial in the early stages, but you have to clearly understand when it starts to hold the patient back. The patient needs to be in the driver's seat of their own rehabilitation. Technology is now at the center of this new push for individual empowerment, because with just a few simple clicks, we can learn about any topic or master any DIY project by simply watching a YouTube video. And we want the same in our healthcare. We are now able to Google our diagnosis and even have access to the best clinicians anytime, anywhere, with no location barriers. The bridge into telerehab was actually not our brainchild. A patient actually made us do it. A former patient had called begging for help because he couldn't walk or even get out of bed. We told him to just get to our clinic and we could help him. And if he couldn't get to our clinic, then he needed to call an ambulance to go to the ER. Instead, he pleaded with us to FaceTime him. That was almost 5 years ago, and live video was something that we were not only aware of, but did not even know the legal ramifications. His persistence paid off, and I did a quick video call with him, saw that he was shifted, and gave him an exercise in bed to correct. 4 days later, he was 85% better and back to work. After hearing how grateful he was, it made me step back and ask, with the technology we have today, why would I ever suggest a patient going to the ER for back pain? Our quest was then to use technology to enable those suffering from musculoskeletal problems to have a fast and convenient access to a specialist or proper care, with emphasis on empowerment and maintaining activity. Direct access allows physical therapy without a physician's prescription. Proper care is the key. All of our clinicians must be certified in mechanical diagnosis. This lengthy training focuses on fine-tuning evaluation skills by observation of movement and changes in response to motion and patient empowerment. And research has shown the improvement in outcomes based on these. Fear is addressed on day one and every visit afterwards. Technology allows us to coach on mechanics as you return to the activity that caused the initial injury, reducing fear and re-injury. All that is needed is a smartphone and strong internet access. The specialist comes to you anytime, anywhere. Just 3 simple steps. Download the app from both Apple and Google Play stores, complete a brief medical history, and schedule a visit. We published a series of case studies in the International Journal of Telerehabilitation, and we're currently gathering data so we can publish our outcomes as well. And that leads us to the most important part, what your results show or your outcomes. Our first case in work comp was actually a 62-year-old truck driver involved in a horrific crash. He had severe chest pain and was unable to take a deep breath, as well as fractured fingers and contusions. After only 9 visits, he was able to return to full duty. Just as bad as his pain was his fear. He was scared to drive, scared to return to work, scared of re-injury, but these were all addressed starting at day 1, which enabled him to return. What about patients with chronic conditions or chronic pain? We initially felt that those with chronic conditions would be better suited for face-to-face visits because of the complexity of the biopsychosocial elements. But to our surprise, those that we found out of work for greater than 6 months that came into virtual care overwhelmingly gave high ratings, stating, "This is the first time someone has listened to me." Telehealth helps to remove other distractions in an office. And of course, proper care that empowers and reduces fear always has the best. Self-pay, this is where we're seeing some amazing outcomes. Patients come directly to us. There's no physician, no MRI, no medications. Sometimes we're seeing the patients the day of their injury or soon thereafter. Because they are paying out of pocket, patients are 100% vested and primed for empowerment. The average number of visits for self-pay is only 1 to 3, and that includes things like herniated discs, sciatica, ankle sprains, rotator cuff tears. We are collecting data based on the patient's age, body part, pain level, functional improvement, number of visits, and satisfaction, and we are most interested in long-term maintenance of function and the reduction of pain. Mass General Hospital just published the data on their telehealth program. They found that not only is telehealth convenient, but it may actually produce better outcomes. 62% of their patients felt that there was no difference in quality between face-to-face office visits and a video consult. And 68% were given 9 or 10 satisfaction ratings for their video visits. To summarize, reducing the musculoskeletal epidemic is simple. First, you need early access to proper care that empowers, keeps patients active, and avoids or minimizes passive care. And the second thing is technology has already empowered each of us because we can easily Google any topic or watch a do-it-yourself video. Technology has also enabled access to the best provider anytime, anywhere. Thank you so much for listening, and please contact us for any more questions or details regarding our program.